Okay, everyone, so welcome back. We're going to have a nice lunch break after this. We're going to have our keynote speaker. We're going to give out a few Fierce Advocate Awards for those of you who are here. But as we start this next panel, it's my favorite topic, which is benefit managers. Not in a good, happy sense, but in like a kind of a sense. So this is Unmasking Healthcare Gatekeepers, Benefit Managers, and Access to Care. Today we're going to be talking about both pharmacy benefit managers. Many of you are familiar with pharmacy benefit managers, and we're also going to have some experts here to talk about vision benefit managers, which is the Doc Access Act in your bill, and sort of what that entails, because it's very similar. They're getting in the way of patients getting care that they need. This is always a great topic for me because I'm constantly going through this as somebody who manages both my mother-in-law and my stepmom's care on their Medicare plans, plus my family's. I am constantly battling somebody, whether it's for eye exams or getting their Eliquis approved or whatever the case may be. I am constantly in a state of battle. I'm wearing my battle armor and I'm going in all the time. So to kick us off here, we've got an incredible lineup, and I'm just going to briefly introduce each one of them. I am using my iPad as my cheat sheet because I don't have a podium, but that's okay. I'm just letting everyone know. But our first panelist, and I had the privilege of serving on a panel a little bit ago at the AOA fly-in or annual meeting, and I was on a panel with both Daniel and Tommy, who are here today. So Daniel Frier is an expert not only in VBMs, which he'll talk about, but also PBMs, which is one of the reasons why I really wanted him here today, because he can kind of bridge the similarities and speak to some of that. He's someone who's dedicated nearly 30 years to navigating the complex world of healthcare law. As co-founder of Frier Levitt and chair of the firm's healthcare group, Daniel has been a pivotal figure in representing diverse healthcare organizations. His work spans from large medical practices to cutting-edge healthcare technology companies, and today he will share his insights on the regulatory landscape and the impact of benefit managers and access to care, specifically vision benefit managers. But both, welcome, Daniel. Thank you for joining us.
Thank you so much.
And then we have Dr. Tommy Lucas. Tommy is a champion for improving patient access to eye care. As the president of View Optometry and the director of advocacy for the Texas Optometric Association, Dr. Lucas has spent over 18 years at the forefront of legislative efforts at both the state and federal levels. He brings a unique perspective on how benefit managers affect patient care in optometry, and we're excited to hear from you. So thank you for joining us.
Happy to be here.
It's good to have a doctor in our midst. We didn't get Mark Fendrick, unfortunately, but he'll be back. We always try to get Mark, just so you know. Anyway, and next we have Darlene Shelton, also knows a lot about pharmacy benefit managers, of course. She is a remarkable advocate for patients with special medical needs. Inspired by her personal journey with her grandchildren's hemophilia treatment, Darlene founded the Danny's Dose Alliance to address gaps in emergency care protocols. Her relentless pursuit of nationwide EMS education and protocol reform has made significant strides. Darlene will shed light on the challenges posed by pharmacy benefit managers and share her own family story. So welcome, Darlene. Thank you. And last but not least, we have joining us for the first time, Monique Flores. She is hailing from the great state of Texas, which is my home state. So is Tommy, actually. And you're in real estate, right?
I am.
So is Dorothea. You guys should talk. Anyway, I just putting that up. But anyway, you're here to share with us today. I'm just going to read what I wrote because I want everybody to know who you are. A dedicated entrepreneur from a proud Navy family. So am I. My dad was in the Navy. Monique has spent 2 decades building a successful real estate brokerage while advocating for her community. Today, she will discuss her firsthand experiences with vision benefit managers and how they've impacted her care. Her story underscores the importance of patient advocacy in the face of bureaucratic obstacles. So welcome, Darlene. Okay. So my first question, we're going to open it up with you, Daniel. Do you want me to call you Daniel or Dan?
Dan's fine.
Dan is fine?
Yeah.
Okay, good. Just want to make sure. I don't like, some people are very picky about those things. I don't want to offend anybody. So just to kick us off, just because as I stated, this is a real pharmacy benefit manager room as a patient advocacy organization. Can you kind of give us the tie of vision benefit managers and pharmacy benefit managers and how they're similar?
Sure. So aside from the fact that the acronyms are almost identical except for one letter, they basically, a pharmacy benefit manager and vision benefit manager serve similar purposes. They are essentially gatekeepers between the ultimate payer, which is either an employer or a plan, and the provider of care. And I mean, I could probably spend a half hour explaining what they are, but I'm going to do this in about 30 more seconds. Pharmacy benefit managers and VBMs share a common trait, and that is that at some point they went from simply being gatekeepers, managing the benefit on behalf of the payer, to a light bulb went off over their head at some point in time, and they realized, wait a minute, there's a flow of money that's coming from here to here through a pipe, and if we poke holes in the pipe, some of that water drips into our pockets. Let's poke some more holes in that pipe. And nobody's watching, nobody knows who we are, and because we control, like in the case of PBMs, we control what drugs go on the formularies. We can control we have control over manufacturers. We have the ability to divert some of that money flow out of that pipe into our private accounts, into what are called rebate aggregators that are offshore. And we can do all of this without anyone knowing it because we don't advertise our existence. You'll never see an ad for a PBM. They don't want you to know they exist. VBMs are really the same way. They really don't want people to know what they do and just the fact of their very existence. A few years ago, my partner, John Levitt, and I were speaking in front of an audience of folks who were in charge of the benefits plans for large employers. And in this room full of people, nobody had heard of a PBM. We're talking about 5 years ago. Nobody heard of a PBM. Now everybody hears about it because there's been a lot of press about it. So we'll probably talk more about it now, but I'll end there.
Yes, we will hear. This is a room that knows all about PBMs. They know all about them. It's true. But it is true. They used to work in the shadows. And when we first started talking about BMs, benefit managers at all at Patients Rising, it was sort of like a whole education process we had to go through. Now, Tommy.
Yes.
As a provider, can you share your experience in working with benefit managers and how they've impacted your practice and, more importantly, your patients?
Yeah, absolutely. First off, it's an honor to be here with you today. I'm really happy to come in and kind of share the story of vision benefit managers, as Dan was describing. Vision benefit managers are a story of the fact that what used to be a vision plan or a benefit has become a completely vertically integrated and horizontally integrated monopolistic structure at this point. So most of this room, I'm aware, understands what a PBM, but honestly, raise your hands if you've heard of a VBM before today. Right, very few of you. So what was obtuse and non-transparent 5 years ago in the PBM space is certainly becoming the forefront in the vision space of the conversation with VBMs now. Roughly 200 million Americans are covered by a vision plan, which is a key critical component of this VBM structure. So how many of you know that you have a vision plan? You're covered by a vision plan. Exactly. So most of you are aware that you have this plan, but you're probably not aware that two giant companies, basically in America, have a duopoly structure where they're covering 65 to 70% of Americans. And this same conglomerate structure has grown up and down, left and right, to control the marketplace so that you have to get services where they tell you to from a preferred provider. You have to get your glasses where they tell you to. Your lenses are made at a specific lab. Many times they own that lab. They tell you what discounts your doctor has to charge. They incentivize your doctor with real money to push you towards products that you may or may not need or want. They control the electronic health records that we use in our practices. That data flows to them so they can analyze it and figure out how to make more money off of you. So this is a space that is incredibly unknown at this point. People are starting to wake up to the fact that you're being controlled by these billion-dollar multinational conglomerates in the vision space. But because the vision space is actually such a small part of healthcare spending overall, Roughly, we always say that the vision space is 1% of total healthcare spending, right? It's about a $60 billion market in America. Well, that $60 billion is a lot of money to a big corporation, right? They're trying to get as much of that as they can. So they're charging you premiums for a plan. It's the smallest part of your benefit structure, so that you don't even consider it, you consider it as an afterthought many times. Your medical insurance premium is very expensive. Your dental benefit is the next most expensive part. And the vision plan part of it is usually somewhere between $10 and $20 out of your paycheck every month that either you're paying for or your employer's paying for. So by the time you get down to that level, you're already fighting with the medical premiums, you're fighting with the dental, where do I get my dental care? And the vision thing is an afterthought at that point. So of course, as optometry providers, we see this happening and we're like, hey, this is going on, this is not right. Our patients don't have the choice that they want in their care. In many communities, they only have one or two optometry providers to even provide that care. That provider practice is being coerced to follow the rules of this plan that don't fit the needs of that small business or the needs of that patient base. So I will kind of pause there because that's a whole lot to take in as well too. If anything, just know that this VBM situation has laid in the shadows for 20 to 30 years, and now it's coming to the forefront. It's something that's been advocated for in states, on the state level, for over a decade now, and roughly 45 states have taken some action on either the vision benefit or dental benefit part of this. And now the conversation has come to DC, of course, to try to impact the plans that are federally regulated, of course, Medicare, Medicaid, exchange plans, ERISA plans, all of those things. So states have already figured out that this is a scheme that's been going on for many years. And now we're here, of course, to talk to our Congress people about these schemes that are impacting your choice and the care that you receive.
Thank you very much for that. I'm going to go into the patient stories next, but one of the things I'm going to just tell you really quickly is a short story about how I have reacted to the VBM space. Like I said, I'm going to talk about this a lot today because I am very ingrained in other people's healthcare now. And I'm constantly taking either my mother-in-law or my stepmom to get glasses or get, a checkup or whatever. All I can tell you is no matter what configuration I do, I use the insurance, I don't use the insurance, I buy the glasses there, I get the second pair, I get shading, I get whatever, it's $750 before I leave there. Doesn't matter what I do. Like, all I can say is, like, it does not matter what I do. I pay $750. Like, I get 2 pairs of glasses. It's like, well, if you don't use your insurance, you can get 2 pairs of glasses at 50% off. But if you do, it is like the craziest thing. So
the system exists to actually prop up prices on patients.
it is like,
It's insane.
yeah, it's totally insane. So I just want to say that I'm sure many of you, since you were laughing, have a similar feeling when you go on this is not quite right. I don't know what's wrong because I'm battling the PBMs over here and I don't know how to figure you out right now, but there's something wrong. Okay, so I want to hear a little bit from both of you, just so we can introduce. I want everybody to kind of have a chance to talk, and then we're going to get into, after this, we're going to get into the Doc Access Act and some of the solutions for some of this that you're going to be on the Hill about tomorrow. So, Darlene, can you share your personal short story that sheds light on the real-life impact of pharmacy benefit managers? Because then we'll segue into Monique doing that for her eye story. So can you tell us about your family's experiences with PBMs and the challenges?
Yeah, so one I have is a personal story, and it's a little less expensive. So at my age, clearly, estrogen patch is important, so that I still have a happy marriage. Tried 5 different generics. They did not work. They just did not work. My doctor hates generics. She said she needs the actual brand name. So, of course, it started the fight with the insurance company because they didn't want to cover it. And long story short, it's $158 out of pocket every month. Luckily, I'm blessed enough I can put that money out. But I find out from a friend who runs a specialty pharmacy that's connected with in Canada, I can get the exact same patch for $58 a month. Now, where's the problem there? The other thing that's kind of a warning, so the insurance company, when I threw a fit, and said, no, the others don't work, I've done your trial, I need the brand name. And they said, well, we had this option where you can do this membership with this company in Canada. Well, I'm not stupid. I do my research. Guess who's a part owner of the company in Canada? My pharmacy provider on the insurance. And at the very bottom, when you were doing this membership, there was tiny size 6 font writing. But of course, I'm going to read that. And it said that your signature signifies that you agree with all context in paragraph 7 on page 4. Paragraph 7, page 4. Guess what? I was giving them permission to access all my personal data, even my college records, all of my financial information. Like, why do you need that to send me an estrogen patch? That is not your business. So I refused. So then Darlene started paying the $158 a month out of her own pocket because I would not do it. And I mean, I went like 3 levels up on management because that is so wrong. And I mean, that's a whole different thing of your private information. So that is one story, much cheaper. But we are a hemophilia family. That's what brought us into the rare disease space and caused us to start Danny's Dose. Clotting factor is very expensive. Danny is 13, weighs, I don't know, just a little, around 100 pounds, 105. And clotting factor is based on weight. $75,000 a month is what it takes to keep my grandson protected so that he doesn't die. Let's just put it out there. That is so ridiculous. That is such an upcharge. And I was going to make sure I was right, but I'm sure it is. I have been told by, within the hemophilia community that the PBMs actually are able to retain 40% of that cost, just because they exist and they play a role in the process. So that alone is inflating the cost of an expensive medication. And many people think, oh, it's the pharmaceutical companies, they're driving up the cost, they don't know about PBMs. It's very expensive. And then, I know we're not talking about copays, but their annual deductible is $8,000. So every January, it's $8,000 to get that life-saving medication for not only Danny, but then also my granddaughter Lillian, and then Zoe has emergency treatment. So yes, they hit their deductible every year, and it's a lot. I mean, it's really costing our family a lot. And if this could get under control, it could really be health saving. And that's just talking about money alone. I can talk more later.
No, it was totally great. Darlene's up here. We're talking about 2 things because we do have a PBM, and I know many of you have PBM stories, and so that's going to be sort of your point of reference when you're talking tomorrow. So I'm also going to be highlighting here towards the end another bill, the PBM. I call it the PBM bill of the moment because we support all kinds of PBM bills. Copays count. I mean, I support anything that's discriminatory benefit design. Not me, but Patients Rising. We don't have them all in your packet, obviously, but I just wanted to kind of highlight one of these stories. Now, Monique.
Hi.
I would love to hear, now yours is going to be totally different because yours is eye-related, but are there similar, that's why I let Darlene go first. It's a different story because it's drugs, but you're still struggling with some larger entity to kind of get what you need.
Yeah, absolutely. So my personal story goes back as early as the age of 2 when my parents realized I needed glasses. I would cry when I'd go outside. The sun would pierce my eyes. So I would say it burns my eyes is how I would describe it. So when they finally figured out to take me in, I found out I have a severe astigmatism. My vision was rapidly changing, and it was affecting every part of me. And at 2 years old, you can't really describe that to somebody. You can't use the right words to tell your parents what's actually going on other than it burns and cry in the sun. And my parents thought for a whole year I outside. And that wasn't the case at all. So my story started there, and at 42 years old, I've had 40 years of vision battles. You know, it's something that I don't have a choice to have as a part of my life. I have to function. And throughout the years and throughout my lifetime, and as I became an adult and had to start considering these things, you know, we know when we budget for electricity, for however we're going to keep a roof over our heads, food, vehicle, now phones. In my case, I have to actually consider my budget and making sure that it always includes my vision, because even though I've always been able to maintain eye care, I know that no matter what, every year I'm going to need new glasses. There's been some years where I've needed them twice a year. And I know that no matter what, regardless of the insurance I've had in the years past, I have always had to come out of pocket for minimum glasses. That's not even including the vanity piece of it, where I don't have thick glasses or glasses that magnify my eyes. And as someone who's gone through this since they were 2 years old, you can imagine the name calling and the bullying and the sensitivities and the confidence issues that come with that. And as you become older and more professional, you become more concerned with the vanity piece of it. I need people to take me seriously in my world, and I don't want there to be a distraction outside of what I'm there to do or serve, or how I'm trying to apply myself in whatever environment I'm doing. And the reality is, I've not always been fortunate enough to be able to afford to pay out of pocket to do these things. And there are times where I would let my vision go another year or 2 or 3, and Dr. Lucas could probably speak to that more specifically, but that's not something I actually have the luxury of doing. But when I didn't have the budget to factor in an additional $600, $700, $800, $1,000+ a year for my base level glasses and eye care and eye health, this is one of my senses, you know? I can't, it's not an option for me to live without. It's not an option. So I would forego sometimes getting these things done purely out of the fact that I knew the expense that was associated to it was not something I could do at that time.
And that's something we hear about a lot. I'm sure many people have had this experience in their room. I know I just experienced it with my mother-in-law, where they go off of something or they don't do something to care for themselves because of a cost factor.
Yeah.
And they don't want to talk about it, and they don't want to, you know, they just sort of make these determinations. So as a provider, Dr. Lucas, how has that affected not only Monique, but any of your other patient stories and experiences where patients are not, because like I said, eye care is one of those things that we think about, and it's like, it is an afterthought. It's not, in fact, last year, I'll be honest, I have to wear glasses too. I'm very blind. If I take them off, I wouldn't be able to see any of you. But I didn't get my glasses last year, as a full disclosure. I did not get new glasses, even though I had a new prescription, because my son suddenly needed glasses. He has a severe issue, and now Jackson has to get glasses every 3 months because he has an issue. And his glasses were going to be such a new expense in our budget and what we were doing that all of a sudden I was like, oh, I'll just get them next year. So this summer I'm going to get new glasses. Hopefully I'll be okay. But do you have that kind of experience with probably people with much more severe things than, you know?
Well, absolutely. I mean, it has a profound impact on patients. The majority of people in this room, the majority of people generally need some type of vision correction. And even though it is an afterthought, kind of in the healthcare world, it's the one thing that you're seeking. You have to see well in order to function in society. You have to be able to drive a car. You have to be able to see your phone, your computer, all of those things. So, you know, generally you know to go to the optometrist once a year. Getting annual eye exams is about seeing clear, but it's also about looking for hidden eye disease as well. So optometrists, we play a part in this vision clarity world, which is kind of housed in this vision benefit manager space, but we also completely participate in what the last panel was talking about in the medical plan space as well. So, you know, when you have diabetes or glaucoma, or a red eye or an injury to your eye, we're dealing with the same deductibles, cost shares, things like that, because those things get applied to your medical insurance. So our patients battle that system basically from the first panel. From this panel right here, we're talking about the vision benefit manager space. And in Monique's case, I've been caring for Monique's eyes for as long as I've known her, for 18 years now.
Yeah.
And she's given me permission to kind of share her eye story a little bit. She has a profoundly high prescription. We've had to go to great lengths to make sure that her glasses are made properly when her vision plan is forcing my practice to use a certain either out-of-state laboratory to make her glasses. I have no clue if they're going to come back correctly or be appropriately designed for her. I know that there's labs near me. In fact, we have our own lab where we can make glasses like within an hour for patients that need them. In her case, her prescription's so profound that if the axis of her astigmatism is off by 1 degree, think about a 360-degree clock. If it's off by 1 degree, that's like two lines on the acuity chart for her. So instead of seeing 20/20, she sees like 20/30. And when glasses require that kind of precision, the doctor is trying to advocate for their patient to have the clearest vision possible, but then enter the world of corporations and what their desires are. They want the doctor to send her glasses to some lab because they own it or control it or have a deal with it. And it disempowers me as Monique's provider, as her doctor, to make good choices with her and help her, get the apparatus that she needs to function well in this life. So, coming up here this weekend, I knew that Monique's story would, resonate in a way that kind of makes sense and brings light to what's going on in this space. Not everyone has a super high prescription. Some people have a mild prescription, but other people have other issues. They have headaches, they have eye strain, they have dry eyes. So there's a ton of things that go on with your eyes that are connected to your vision and what type of glasses or contacts or corrective surgery that you could potentially have. So the eye world is very interconnected to your overall health. In fact, coming to your optometrist is generally one of the first places where you enter into the healthcare system because you're trying to get your vision corrected. And then when we find that patient has diabetes, or we see signs of cancer in the eye, or we see signs of autoimmune disease in the eye, we're getting our patients to the appropriate type of doctor to manage those things. So optometry is just an instrumental part of the healthcare system, yet we have this corporate structure that's trying to cannibalize that and force patients into their umbrella of money making. And that's kind of what the system does at this point.
That's one of the things that will never make sense to me, and I'm sure that is for many of you as well. Getting your medicines, whether it's at a specialty pharmacy, whether it's a specific lab, or it's down the street. Why can't I go down the street? Like, why? What's wrong with down the street? I just can walk there. I can drive there. I'm done. I know where my stuff is made. I can walk in. I can take it back there. I don't have to go to and first of all, I am the queen. This is just a side note. I don't ever return anything. Amazon loves me because I'm just like, I don't have time for that. I just don't. I don't have time to put that. And they make it so easy. But I don't even have, if it's really expensive, I do make time. But for the most part, I'm just like, all of a sudden it's like the 30 days are up or whatever and it's over. So you have all these other situations and barriers that are put in place. So what I want to do now, as we on the second half of this panel, is talk a little bit about the solutions that are in your packet. So, Dan,
Yes.
I'm going to say Dan, can you tell us provide a little bit of an overview of the Doc Access Act and its kind of significance in this space? Or do you want is it better for Tommy to do that?
If you want to go first.
I was going to have you kind of give an overview of it, and then you kind of talk about where it's sort of where it's passed and how it would impact you directly. Does that work?
That's great.
Okay.
So, the Doc Access Act is a law that seeks to limit the ability of, among other players, vision benefit managers, from utilizing their vertical and horizontal integration to benefit from the inherent conflicts of interest that arise whenever you have a gatekeeper who also sells products and who also is providing insurance coverage. And this is a type of conflict that the states cannot deal with on their own. They can't deal with it on their own because there's 50 states. The process of getting 50 states to pass laws is incredibly arduous. Plus, there's something, I'm sure some of you may, in the PBM space, understand, ERISA preemption, where basically if a state tries to pass a law that in any way overlaps with ERISA, the state law is deemed to be invalid. So states can pass all the laws they want. Many of them will be challenged by the VBMs and the PBMs as being in violation of ERISA. ERISA preempts it, and so these are laws that have no teeth. So federal legislation is really the only way to deal with this. In the PBM space, there's Medicare. There's certain, like Medicare has an enabling provider law that protects independent pharmacies, for example, and physician dispensers from being kicked out of networks. There's no such thing in the vision plan space. So there's a natural tendency for the VBMs, like any gatekeeper, to want to limit the number of providers because in doing that, they can control providers. They can control how much volume they're getting for the products they sell, but for their labs. If you have too many providers, the tendency is that there are too many people that are going to doctors, and that costs money, right? Even though that's the kind of access that the public should expect, right? Access to care. I mean, that's what we want in this country. But that is antithetical to what the VBMs and the PBMs want. They want to limit access. They want to make it difficult to go to a doctor and spend money. And then when you do go to a doctor, by controlling this limited number of providers, they can have greater control over selling their products to those providers. They effectively view optometrists as their sales force, their unwilling sales force. That's essentially what they look at them as. The Act, and I'll just mention it briefly and then I'll pass it along. The Act is designed to deal with some of these issues. For example, it would prohibit VBMs from steering patients to their own manufacturers and labs. It would give patients and their doctors total freedom to prescribe and to recommend any products that they felt were deemed appropriate. If it happened to be a product that was owned by a VBM, so be it. But they'd have to play on an equal playing field. It would limit the ability of the VBMs to require the providers to enter into long-term agreements that are automatically renewed without really any ability by the providers to prevent that. By doing this, it would increase competition, which has the impact of improving access. And that's really the goal. The goal is not, this law will have the inherent advantage of helping the providers, which is good, but at the end of the day, really what it's really good for is protecting the public by providing greater access and improving competition. There's a number of other elements we can get into, but I'm going to pass it along a bit.
Well, one of the things that I'm going to point before I toss to you is vertical integration is something all of us know in here. And if you don't, I'm going to explain it. It's what we've all been experiencing where United Healthcare owns the PBMs and United Healthcare and your doctor and your whatever, your MRI machine and everything else. And now 3 pharmacy benefit managers and insurance companies have all merged, and that vertical integration actually causes healthcare costs to go up and it causes access to go down because they limit it. So I'm just kind of.
It seems so corrupt. Like I'm like listening to y'all, and I had let me just say this, I have the lowest level of understanding of all this. I'm a patient and I have my own frustrations that I've battled over the years, but like listening to your description, it's gross. It's gross to me hearing this as a patient, as an employer who has to provide these cares. Like I'm trying to control my fumes right now while I hear all this, but it's infuriating. It's absolutely infuriating. It sounds corrupt.
Oh. We've converted another one. No, there we go.
I call it legal money laundering.
Yeah.
Yeah, it's
I'm sure there's probably a lot of words you could call it.
legalized kickbacks, for those of you who know Marion Mass. That's what she calls it. Legal kickbacks. Okay, so can you share with us a little bit about the policy overall and how it would benefit your...
For sure. So we have the Doc Access Act that we've been working on here in DC for a couple Congress cycles now. The policies that are within the Doc Access Act have already been implemented or in law in over half the states in the vision care space. The Doc Access Act is not purely a vision space thing, it is a vision and dental space thing. So just like I'm describing what's happened in the vision world, this whole story exists in the dental space as well. There's just not a dentist here to tell you about it right now. So the Dental Association, the American Dental Association, and the American Optometric Association have joined forces to try to propel the Doc Access Act. And the Doc Access Act components are this lab choice piece so that your doctor and the patient can decide what covered products that patient needs and where they're made at that's best for the patient, whether it's getting your glasses and contacts or dental appliance the fastest, whether it's getting the best quality that the doctor knows is gonna be the best for you. It's that piece. So we call this lab choice. So that's kind of like how we describe this because obviously the manufacturing of the product side of this is where money is being made by these VBMs and the dental plans. The other piece has to do with non-covered services. So you can imagine that, you know, you buy this vision plan. That vision plan has a set of coverage. The doctor signs a contract saying, I'll provide those covered services for X amount of discount. That's kind of what insurance is, right? Well, then the VBMs want to also control what the doctor provides that are non-covered services. So they dictate prices to the doctor on what we can charge or what discount we can offer, and that has a very big impact on competitiveness. They do this in order to make their plan even more attractive to purchasers, right? So your employer or the government or whoever is buying this plan for the patient, they're like, great, no, we have these covered services and we're forcing all of these discounts. So it's even more attractive to have this plan, right? Well, here's the real world impact. Doctors and small practices, you know, we have to run our businesses at a certain margin to stay in business. And when a practice is dictated to price, what is the immediate response? The doctor has to raise their prices on their usual and customary charges, whatever it is, to stay in business at that point. And these are over for services that we never agreed to be in the contract for those covered services. They're kind of related to optometry or dental, so that may be like a discount on a second pair of glasses, or it may be orthodontia or something if it's not covered in the plan. So they're trying to provide you with as little covered services as possible, but dictate the prices on non-covered services to keep selling their product. So that's a little bit in the weeds. It's kind of like a little bit of economics, but we all understand that here in this room, that the schemes that are being played with covered services and non-covered services are all intertwined to keep money at the plan or to make more money for the plan.
Is that why they all try to sell you a night guard and whitening for your teeth? I know you're not a dentist.
I can't speak to that part of their plan designs, but
Does anybody?
It
I mean,
sounds
don't you
like
every
what
time
they
you go
would
to the
do.
dentist, they
Yeah.
tell you need a night guard?
Yeah,
Do you
yeah.
need a night guard or not? I did get a night guard one time, but I won't put it in, so it's not working for me.
yeah. But-
Yeah, I just do other things.
Yeah.
That was just, I was being funny.
Yeah, price control here is, and non-transparency are the two elements that keep these plans in power and keep them making money. And what do they do with the money that they made, all those excess profits that they're making? Well, they're buying up the industries. They're buying up the vertical integration supply chain, and they're buying horizontally related companies with all of those profits they've been making for 20 and 30 years. So it's classic monopolistic behavior. In the eye care space, we kind of have a duopoly where there's two major plans fighting with each other. But of course, the economic power that comes from that duopoly is what is creating the system at this point.
Yeah, so they have only two. We have three in there, but they have only two. Of course, they have a much smaller pie, as we talked about. You're a much smaller part of the healthcare expenditure pie, which is why you sort of fly under the radar.
That's
and why
exactly
all of
right.
that stuff kind of flies under the radar. Now, I want to highlight a few things on the Drug Act, which is the delinking. You guys will have to tell me. I don't have it in front of me. It's the Drug Act. It's the PBM bill. But it is delinking. Delinking utilization. Delinking revenue from unfair gouging. How could I forget that? Because that's so true. Anyway, I just want to highlight a few things on this. We've made the Drug Act one sheet very broad. We do support the Drug Act. We support it. It's got a House bill. It's got a Senate bill. It talks about some of these things here that we're talking about. The steering is in it, so there's steering in your bill as well.
Yes.
This is also anti-steering, the Drug Act bill. And Marionette Miller-Meeks, who's going to be here later, is one of the co-sponsors of the Drug Act, just so everyone knows. She'll be here in about an hour, or a little bit less than an hour. So there's that. And the other piece of this is delinking what you pay from the price of the drug. So it's or from the list price of the drug. So it's bringing it more into, the realm, because many of you know, you'll experience, oh, I'm paying the such and such percentage on whatever the list price of the drug is, and anyone who's in this room knows that's a bunch of bunk. Like there's nobody paying, they're not paying the list price of the drug. Why on earth should they charge you on that particular piece? So it's delinking revenue, their revenue from your price. That's the big piece of that. So I'm just going to tie this kind of up in a bow dart for that particular piece. How would that benefit us, Darlene? I mean, delinking that. I mean, I know you were talking kind of about copay accumulators, but when you're talking about such a high price, if you're stuck paying, if you're getting billed, whatever the percentage is on the list price of your medication, and they were going to all of a sudden take the 40% off,
Right.
as you were talking about, right?
Right.
And charge you on that, or make your copay on that.
Right. So,
It's just-
I mean, let's face it, if you have to add 40% to the cost of something so that you can keep that 40%, you've inflated it unnecessarily. And then you're passing on to actually the drug companies. And it's convoluted. I mean, I think everybody in this room probably knows that the PBMs are primarily owned or in partnership with drug companies, and the drug companies are insurance companies, not drug companies, insurance companies. And then they also have bought specialty pharmacies, and when you have privately owned insurance, you are now forced to use that specialty pharmacy. So care has plummeted. And another issue with that, with like contract pricing or formularies, so many patients with bleeding disorders have suffered from it's not even really the fail first. It's the fact that we made a contract to get X medication at this much money, and that's what we will give you is X. When we have individuals that it is proven that clotting factor does not work on them. So I could fill this room with individuals, parents that have had to go through that have gone through 3 to 4 months of continued bleeds, hospitalizations, because they were forced in the middle of having absolutely no care. So it would make a world of difference. A world of difference between choice of specialty pharmacies and the care that you get from them. It's IV infusion. When they're young and you haven't learned yet, you have a home health nurse. Imagine the difference between a company that really wants to provide good service like our grandson had. We had the same home health nurse, and we knew he could be there in 2 hours. We didn't get potluck. And how many families now, it's, some nurse of 20 that's going to come that has no relationship with your small child, that's now going to start an IV, and they're already afraid. And it's a mess. It's such a mess all over. And it's because these conglomerates have now been created, and they are all about the bottom dollar, and they are not about patient care and patient rights.
Which is what we're showing to Capitol Hill tomorrow to talk
Right.
about. Absolutely. So as we wrap this up today, which we are about to do, Dan, you have any closing thoughts for us on the bill tomorrow? Any parting words for our advocates?
The parting words are that these are difficult things to pass because the PBM and the VBMs have incredibly powerful lobbies. And who they listen to really they listen to providers, but they really listen to patient advocates, patients. That's who they really care about, because that comprises a huge part of their constituents. So what you're doing is incredible. I'm so proud to be part of this. I'm focused heavily on the provider side. I don't really deal with the public as much. And I can tell you that the providers are so frustrated. Employers are starting to get frustrated. And another thing that I want to mention is if any of you work for an employer that is self-insured, your employer has a responsibility to start thinking about their interactions with PBMs and VBMs and whether they're getting their employees their money's worth. There's a recent case filed against a large employer, and there was a settlement for hundreds of millions of dollars, and it involved an allegation that the employer really breached its fiduciary duty to its employees by not taking a closer look at how these types of plans are dealing with. So keep your eyes open for opportunities to poke the bear.
Which is what we're always trying to do. Isn't that why we come to town, to poke the bear? Tommy, any closing thoughts for our advocates today?
Yeah, this meeting is awesome. It comes at a perfect time because the conversation in states and nationally is turning towards what are we going to do about rising healthcare costs again. Well, there's a reason why healthcare costs are rising. It's because there's middlemen involved, there's insurance companies involved, and there's a frustration level at this point on the provider side, on the patient side, on the employer side, everywhere at this point that's going to lead to some sort of legislation or some sort of policy change. And like I said, it may not be this year, maybe next year, but that conversation is going to happen again, just like it happened a decade ago with the Affordable Care Act. So the Affordable Care Act did some great things. It did some things that had probably unintended consequences, and here we are again having this national conversation again. So the dental space, the vision space are small pieces of that. The medical space is the big chunk of the economic policy driver of the legislation, but you've got a powerful voice. Legislators, in all my experience of working with Texas legislators, they want to hear from real people, right? Because you're the voters, you're the constituents, and the providers, we go and talk about the inefficiencies and the policies and the small business issues we have, but they really want to hear from you guys. So, highlighting, your problems with accessing dental care, highlighting your problems with accessing your eye care and the kind of conglomerate behavior that's going on and how everything that's happening that we've described today, all those are stories that legislators need to hear so that there's reform in this space.
Absolutely, which is why we're all here today. I want to thank you all for joining us for this panel. We're really appreciative for you educating us on this piece. I want everyone to, now we're going to have a little bit of time for you to enjoy this fabulous catering. Isn't that good? Who enjoyed their